शिनोय सर, आपको स्लाइड शेयर करना आता है ना?
He can share anything and everything.
You can
I'm
teach
just
that also,
kidding.
ma'am.
He's organizing a webinar from CIOMS. So I'm just kidding. Pulling his leg.
No, but Abhilasha, I had a trial run today because having a MacBook sometimes can be tricky.
Yeah, I know.
Because of security issues. So वो आज करके देखा तो it did work at that time. Let's see how it does right now.
It will be.
ऐसा है.
Good. How is the situation in Aurangabad, Dr. Vijay?
Sir, we have 1700 new patient.
Oh my goodness.
A huge
That's
number.
very high.
Yes,
Huge
sir.
number.
After Mumbai, Pune, Aurangabad only.
I think we are already heading for the herd immunity now.
Yes, sir.
Hope so. The recovery rate is also good.
Yeah, more than around 1000 patients discharged.
Okay.
Oh,
Only
very
active
good.
600.
Really nice. Very nice. शिनाई सर बहुत गोरे हो गए और अभी तो अंग्रेज लग रहे हैं.
Anyway, भैया हमको भारतीय रहने दो, वही खुश है.
अभी बाहर जाना नहीं है.
कहीं बाहर जाना नहीं.
Sir, MSc MSM is sponsoring a trip to all the speakers. Next month.
I hope it is not to Beijing.
Wuhan.
Good.
The great Sharan joining. My teacher is there, Dr. Ramnik Madan.
Good evening, sir.
Good evening, sir. Welcome, sir.
Sir is usually only here.
Arun sir, good evening.
हाय गुड इवनिंग, कैसे हो?
एकदम मजे में सर.
क्या चल रहा है? Rama sir.
Yes.
Good evening, sir.
Good evening.
Hello, Arun sir.
Hi, how are you?
Good.
Arun,
What about you?
I'm so sorry I could not answer your query yet.
नहीं, कोई नहीं sir.
Oh, yeah, you had sent me something, but
We'll talk about it.
This is so Ramakrishna.
सर वो मेरे अभी स्टूडेंट्स थोड़े आने वाले हैं ऑनलाइन, मेरे यूजीस भी.
Yes, sir.
और फिर का है जो मैं
I can see Hirkani, Sharan.
Yes, sir.
Yeah. मेरे को डर लगता है तो बड़े बात है ना. Aishwarya. Somi is there from Bangalore. Thank you, Somi, for joining.
Only one mark.
And so many more. Actually, I'm quite honored to have so many people.
Sir, we are waiting to listen to you.
Oh. So we are having a change, Sharan, this time. That whenever there is a question,
Okay, sir.
we will be answering.
Sir. Sir.
So these are the instructions Vijay Gire gave to me.
नहीं, अभी I think morning मैं उठ के अपना शक्ल देख लिया शायद आज.
ऐसा है.
Yes,
तो
sir.
अच्छा रहेगा अगर क्योंकि क्या है बॉस लोग हैं तो फिर हमको कोई डर नहीं है.
नहीं सर, बॉस का बॉस आप है तो क्या टेंशन देने का. आप है बस चलता रहेगा गाड़ी.
चरण सर गुड इवनिंग.
सर गुड इवनिंग अरुण.
कैसे है सर?
बस बढ़िया यार. गुड वीडियो मेड.
थैंक यू सर.
Arun is a very creative guy.
Yeah,
Thank
yeah.
you so much, sir.
Vijay, have you enabled screen sharing?
Just a moment, sir. Sir, enabled.
Okay, thank you.
People are joining in, so we'll wait for 2 more minutes.
Okay. Let me just see if I can start sharing. That's why. Okay.
Sir, visible, yes.
Okay. So I'll just keep it on full slideshow.
Yes, sir, please.
Hi Rama, all the best.
Thanks. Thank you,
Mukul
Mukul.
sir, good evening.
My teacher, Dr. Mukul Padhe, is here.
Good evening, Rama. All the best.
Thank
Good
you.
evening, sir.
Record. Hi, good evening. How's your leg?
Better, much better.
Very good.
He has,
Record number of people today, Rama.
he has indicated that nobody should start pulling her leg now. Mukul, don't say
Yes.
this.
Pardon me?
Mukul, it puts the scare in me actually.
Acha.
So,
I think you should start now.
Yes, sir.
I don't mind. Okay.
Good evening, all. I welcome you for this webinar. Yesterday, we have finished with surgical oncology. So today, honor, we are starting with maxillofacial trauma. And we are honored to have one of the senior most faculty from Maharashtra to share his view on primary trauma care. And we are fortunate to have Dr. J.B. Garde sir as a moderator. Dr. Garde sir is a professor and PG guide at Rangunwala Dental College, Pune. I request Garde sir to introduce Rama sir and then we'll start. Over to you, sir. Garde sir. Hello.
Sir needs to unmute himself.
Hi, Garde. Good evening. We can see you.
You'll have to unmute Janardhan.
Am I audible?
Yes.
Yes, yes.
Good evening, all. It's really honored to introduce my elder brother, one of the most dynamic personality in oral and maxillofacial surgery, academics and clinics. He's really lion-hearted person. He doesn't require introduction, but briefly, I'll just tell him his career. He did his BDS and MDS from Government Dental College, Nagpur. Currently, he's working as a vice dean and head of the Department of Oral and Maxillofacial Surgery, UHPM Dental College and Hospital, Nagpur. He's got a vast experience of more than 26 years in oral and maxillofacial surgery. He's also PhD guide. He's got more than 60 publications to his credit, and he's to national body of AMSI, and he's also executive member of AMS of Maharashtra State. And to be honest, he's my elder brother, and I'm really glad to introduce him. It's really honor to have him here. Rama sir, please go ahead.
Thank you. Am I audible?
Yes, sir.
Thank you, Vijay, and
Yes, sir.
thank you, Jana. Thank you, Mukul sir. So actually, those were two kind words to me for me. And Vijay, you said that I'm one of the senior most. I may look old, but I'm not that old. So anyway, so I'm going towards what Mukul looks like actually. In a few years, I am not going to leave the home. So, going ahead, what is very important nowadays is the incidence of maxillofacial trauma that is increasing. And we as maxillofacial surgeons obviously have a big role in managing it. And why not? Because that is one of our core strengths, that we should basically be the ones who should be called first. So when a patient comes to the maxillofacial, to the casualty or to the ER, I think we are incumbent to deal it in the best possible way, to a multidisciplinary approach, that is take help from fellow colleagues from other specialties, and then render the best treatment possible that can be done. Now, uh, okay, I was fortunate to have these people as my teachers at varying points of time. And I have a submission here that yesterday night, Dabir sir messaged me that he wants to speak to me. And what he told me is something, that is going to be firmly etched in my heart, always in my life. He gave me such wonderful words of encouragement. Thank you, Dabir sir. And I remember as my first year of MDS in 1991, the conference which was held in Ahmedabad, sir had taken over as the president, and it was a very memorable conference. In the center, we see Dr. J.N. Khanna sir, who is also a teacher of teachers, and of course, Dr. Diwan, who is an authority in maxillofacial surgery all over India. So I was fortunate to learn a lot from them. Now, this presentation is not going to deal too much in COVID, because we've had discussions on it. Abhay has dealt very wonderfully on it. So we're not going to deal with COVID and emergency facial trauma. That can be a topic that we'll discuss sometime later, I think. Right? So these are some of the cases that routinely come in our practice. Sometimes even worse. Some people are, I should not say fortunate, but they get to do more cases than what we do. So, it's always, when we have webinars or scientific meets, it's always an exchange of thoughts. And I would always welcome something that comes out of this discussion. So when you look at the CT scan in the center, it looks scary, right? This is one of the patients that we had. And of course, we are fortunate to have a good neurosurgical unit with us, where we work in tandem with them to render the best possible treatment to the patient. As we come to the discussion part of it, we shall say that, we shall come to know who takes priority over what. And obviously, maxillofacial surgery comes as a part of the secondary survey. There's a story which I need to tell you at this point of time. I was a lecturer in the government dental college, and I think I was conducting a preliminary a part completion test, and my house officer comes and tells, sir, एक fracture mandible का case आया है. And that was a Monday, and GDC we used to operate only on Mondays. So on a Monday, if the case comes, then obviously the patient has to wait for another week if the patient needs to be done under GA. So GA was a luxury for us. So this lady comes and tells me, sir, I have admitted a patient. She's a house officer. So I said, can you get the patient? And she just very innocently said, fracture mandible. I said, can you get that patient? I'm not going to tell her name. So I get to see that patient on a stretcher, and it kind of shocked my wits, because what happened at that time, I'm talking about early 90s. Nagpur, in summer, we used to sleep outside in the terrace or in the garden, wherever. And this gentleman, who the patient, had been attacked by his tenant with a sword, and the sword went right from the outer canthus of the left eye, coming down, splitting the cheek, the lip, the upper lip, the lower lip, and a tiny part of it was the fracture mandible of the parasymphysis. Now, the point that I want to drive here is that it is important that we recognize. Can you see my slide, please? Hello?
Yes, sir.
Yes, sir. Yes, sir.
Yeah. So the thing is that, we need to decide what takes precedence, okay? and how we manage it. Because she just came and said fracture mandibular, maybe I would have seen it later at about 4 o'clock just before going, because and told one of the residents to do the at least horizontal stabilization. Now this shocked the wits out of us, and me and the other resident, I was a lecturer, the other resident who was there, they all joined. We joined, and then we got nice closure. Yeah, was muted. So the issue is that we should recognize everything. We should look at the patient holistically, right? And then we should drive our treatment in that particular way. Okay. Now we have so much of maxillofacial injuries in our country, and it pains me that in the initial period of COVID-19, when the lockdown happened, uh, for about a month or so, month and a week or so, we had no issues. But then later on, what happened is that once the liquor lockdown was unlocked, then all the mayhem started. And on the first day of the unlocked liquor, unlockdown of liquor, we had 12 cases in our unit. And believe me, we are in the periphery. Though we are a tertiary care unit, we are in the periphery. So you can imagine how many cases would have been there in the center of the city or in the government colleges. So we have ample of literature. What I would like, I believe that there are a lot of residents and trainees in this webinar. So these are certain articles, and I've got references at the end of it also. So you could just go through them, and these are extremely detailed analysis that one can see, right? And uh, read up on whatever is there. I cannot do justice in 1 hour, 10 minutes or whatever. Because when you talk about primary management, it is such a vast thing, because you're not just talking about putting brittle wires or doing an intermaxillary fixation in the casualty. You're looking at the patient as a whole, right? A holistic approach for managing such patients. So if you just spend some time in these particular articles, you'll get to know. Now what happens is that we have seen that when a driver puts on the seat belt and in a car that has got an airbag, he or she is pretty safe. But what happens if you look in this video is that a passenger sitting on the back side, how violently he gets thrown forwards, and not only hurting him, but also the person sitting in front of him. So you can realize what sort of injuries that such patients have. In the usual, when we see the Bible of maxillofacial surgery, that is Rowan Williams, we see that image where the passenger is driving and the car hits something, and at the end of it, the femur, the sternum, and the facial bones suffer fractures. But have you ever imagined the catastrophe that can happen when you have a passenger not wearing a seatbelt on the back seat? So it is extremely important that we instruct the person sitting at the back also to wear a restraint. That obviously would reduce the injuries to both the backseat passenger as well as the guy sitting in the front. Now we all know that road traffic accidents is the usual cause of accidents. From paper to paper it may vary, but usually in India we see that it is road traffic accidents. In the West, road traffic accidents don't cause so much as assaults or falls or industrial accidents. So that is how demographically the prevalence and incidence of maxillofacial trauma happens, right? What are the concomitant injuries? Now, this is something which this article has come from the Jai Prakash Narayan Trauma Center of the AIIMS in New Delhi. where they analyze 546 cases in 3 years, right? They get so many injuries. So this article says that usually it is the pelvic and limb injuries that happen. And obviously, rightly so, because in a vehicular accident, where usually which are the cause of road traffic accident, the person tends to move forward and hit his knees right in the dashboard and fracture the femur or the pelvis, right? So this tells us that what other injuries can happen to such patients. So we should also examine very nicely the other parts of the body, which we'll see in the secondary survey, right? No, no great deductions over here, because obviously males are more involved in traveling or in assaults or in sports. So usually you see that there's a very big male predilection, what you see over here. The second thing is, another important thing here is, if you see that it is this particular age. Now, if you see the age of 21 to 30 and 31 to 40 are the ones which are usually affected. Why? Because they are the ones who are in the most productive age. They would be the ones who would be taking more risks, traveling, sports, whatever, right? So they are the ones who are more affected in road traffic accidents and obviously in maxillofacial injuries. Those who attended Andrew Hedges' webinar by AMSI, and in that particular incident, in that webinar, Murthy Halsnar from the UK gave a very important pointer. He said that if there is a pediatric fracture, right, pediatric facial fracture, one should not just look into the fact that it is a case of a trauma. But if such a case comes, then you should always suspect child abuse unless proven otherwise. Like if there's a family traveling in a car and then they meet with an accident, so it's obvious that this child also suffered a road traffic accident. But otherwise, one should always make sure that if there is a pediatric fracture with no other person getting injured, then obviously it should ring a bell saying that it could be a case of child abuse. And they have a particular protocol where I don't recollect which agency is it, but I'm sure that in India we are going to get such things in days to come, right? Then this is another graph which shows the time of injury, 6 p.m. to 12 a.m. People get drunk, they meet with accidents, hit each other. So this could be another thing. And the second thing is that if you see this particular time, I don't know, it varies from study to study. But in the mornings when somebody is traveling on the road and they usually doze off, right? And that can cause an accident also. And at that time, your level of catecholamines are the highest, right? So this is one figure. Then this shows obviously no guesses, mandible is the highest, right? Followed by ZMC and so on and so forth. So these are the different injuries that one can come across, and one should be you should be aware of these things that happens. This particular article which has come by Dr. Roy Chaudhary and his team is extremely, it gives everything in detail, and one should make sure. Those interested, I will send a copy of it, or you people are very smart, you can get it yourself, right? So these are the different articles and literature which tells you how to do it and what one should look for. Okay. Now, what is the problem? Why are we so concerned about the maxillofacial trauma? Okay. You are in a zone, you are dealing with a zone that is highly vascular. Okay. The face is very vascular. Number two, if you look over here, you have the cervical spine, right? And number three, you have the airway. What can happen that, you just don't get an isolated fracture mandible. If you're lucky, it's something like that. But otherwise, there could be in severe injuries, you could have a fracture of the larynx. Now, if this thing happens, it's extremely difficult to maintain the airway in the routine fashion, right? You cannot put a Guedel's airway. You may need to do a tracheostomy, right? Very cautiously, right? Otherwise, also there could be a case where you see the fractures of the cervical spine. Now, this is an absolute emergency, which we'll see in the next slides, right? Another article which gives the ATLS guidelines, right? And unfortunately, like we've got so many protocols that have come up in the Corona times, we should also make sure that our association gives, proper guidelines, and we propagate all these things. When I was preparing my lecture, I saw a few videos on ATLS, right? And the way it is implemented and it is taught, right, it is propagated, it is fantastic. You cannot miss anything when you follow those particular guidelines. I will be showing a video later, right? So these are obviously they're a frequent cause of presentation in the emergency. There is somebody who wants to talk other than me. So varying from simple nasal fractures to gross comminution, and these sometimes these injuries can be very challenging. Right? We have to reconstruct the face, right, to the pre-morbid condition as much as we can, as we should. Right? These injuries may appear minor, but can. Can I request everybody to mute their audio other than me, so that I can be heard more clearly?
Sir, I am muting them. You continue, sir. But there are many people who are joining in. That's why there is issue.
Okay, no worries, no worries.
I'm muting them, sir.
Yeah, don't mute me, huh?
Hello, sir. If there are many people who unmute, I will mute all. Then you unmute yourself.
Okay. Yeah, sure. So the initial assessment of the trauma, it depends on the patient's injuries, and we should assess it very rapidly and in a systematic manner, so that whichever injuries are there, they should be dealt in that particular list of priority, right? If we feel that we are fresh with knowledge, we know that we are go-getters, but if we neglect a particular sign and the patient has some fatality, then obviously we'll be dragged to the court, or how things happen in India, right? 25 to 33% of the deaths caused by injury can be prevented. Okay. Now it has a trimodal distribution of death. This is not very important to know, but then if since there are there are a lot of residents in this group, so you have the first peak, right, which happens in seconds or minutes, which is laceration of the brainstem, the upper spinal cord, injuries to the heart and aorta. The second peak, which happens in a few hours, which is the golden hour, where there is damage to the central nervous system or hemorrhage. And the third peak, which occurs, is within days or weeks, which because of infections, multiple organ failures, or pulmonary embolism, right? So the injuries can be classified according to their severity. That is 5% of the injuries, they are severe, right? Which interfere with vital functions, and this is very important, they're an immediate threat to life, right? So then you have the urgent ones which need urgent attention, but they're not very severe. So they have stable vitals. This includes our orofacial structures, okay? And non-urgent is which may require surgical or medical intervention, okay, later, right? Which have absolute stable vitals. Now, what happens is that if there is a mass, a big accident, there's a mass casualty, so we need to triage the patients, and this can be done very effectively by using the Glasgow Coma Scale. This is the gold standard of assessing the injuries, right? Especially for us, right? So there are different scales or scores which are there. So you've got the Glasgow Coma Scale, and this uses, one can remember something in India, EVMs are very common, right? It's a common controversy. So you have the I, verbal response, and motor response, EVM, right? Then you've got the revised trauma score, mangled extremity score, and the injury severity score. So, but they are not important globally, or at least in most of the units all over India. one would be using the GCS, right? Now, what is GCS? GCS was something that was devised by Teasdale and Jeanette in the year 1974, right? What is it? Now, simply explained, right? You have the eye opening. If it is spontaneous, it is, you give a score of 4. If the patient responds to speech, then it is 3, not spontaneous though, and to pain is 2, and no response is 1, right? Then motor responses, the patient obeys, okay? In the one lesser to that is when the patient localizes. If the patient withdraws to some painful stimuli, that is, it's given a score of 4. And you got the abnormal positions, right? Which is abnormal flexor, that is decorticate, and this is decerebrate, right? Which is given 3 and 2, and nil means 1, okay? And then last is verbal response. So if the patient says, when you ask the patient, which year is it? And if the patient says 2020, then obviously the patient is oriented, right? And if the patient says it is some vague thing, then obviously the patient is confused. Like he may say 1907 or 2011 or whatever, right? And then there are inappropriate words. Then there are incomprehensible. That means the patient is not, very coherent in what the patient is saying. And there is no response, means nil. So the worst score is 3 and the best score is 15. So any score between 13 to 15 is what a maxillofacial surgeon should touch. Now this is a mnemonic which I've got from the net, right? This will be good for the residents. This is a mnemonic where the eye response is taken by the acronym ESPN, right? That is eye opening. Okay, you give a score of 4. Sound, open your eyes, is 3. To pain, it is 2, and no response is 1. So if you remember this mnemonic ESPN, I'm sure you're going to do very well in your exams, right? Then the next one is verbal response, EVM. We talked about E, this is verbal response. So our country wins. So cricket is like a religion in India. So R is oriented, country is confused, okay? So where are you? I'm in a hospital. I don't know, maybe in a hotel, right? Inappropriate words, you ask something, where are you? The patient says cricket, hotel, obviously patient is not verbalizing properly. And there's no responses, a single score of 1. When you come to motor response, you can just remember this mnemonic, can't live without fans, okay? And then appropriately, you give the scores, okay? So the least is 3 again, and the worst is 4. Now, where did I get this from? I got this from Intellect Medicos, right? Okay. Now, there are situations where you may not be able to get a response, so you give a score of NT when the patient is, suppose the patient has got lost an eye or whatever, so obviously you cannot test it. So it is not tested. The patient is unable to speak because of some defect, then obviously it is not tested, and motor is again not tested. These are rare situations that can happen, okay? So this is something that could be helpful for our residents. Now there are there are other scores also, like the trauma score and the revised trauma score, then which is based on a combination of Glasgow Coma Scale, the systolic blood pressure, respiratory rate, and by which you get the value, right? That is the revised trauma score value, which is seen over here. If you have any questions, please put it in the chat box, right? And this is the survival probability with the revised trauma score. Now, why am I talking about all these things, right? Because we have a big responsibility in the for the life of the patient, right? We cannot just go and enter. We see a mid-face fracture, a bad fracture, and we feel that the patient is ours, and then we should go and operate. We should obviously take care of the systemic conditions that the patient may be having. Okay, so it is extremely important that we look at all these things when we see a patient of trauma. Then this is injury severity score. This is just for your information. Glasgow Coma Scale is very comprehensive, and then we can obviously go into this. This might be used by so many other surgeons also, but across India, GCS is something that is valid score, right? This is AVPU scale, that is aware verbal stimuli. P stands for painful stimuli, and U stands for unconsciousness. This is also something that which is used in certain centers, but not ours, right? Now, this was something which is given by the Stanford Medical University. And there's an extremely simple thing where you can just check the patient's neurological status in 5 seconds, right? So you have, the cortex, right? The brainstem and the cerebellum, right? So what happens is that you can check the cortical functions. The brainstem is important because that is where the cranial nerves come and go, right? And the last four, that is the cerebellum, the deep tendon reflexes, sensory reflexes, and motor reflexes are checked this way. Okay, so this is a very good mechanism by one where one can check the neurological status. Now, why is it important? Because all these things, when a patient comes with polytrauma, we need to understand the disability, right? So the problem related to airway, breathing, and circulation, perform perform a focused neurological examination. They should include a description of the patient's level of consciousness using the GCS, as well as assessment of pupillary size and reactivity. We should know the essentials of it, right? You're not an ophthalmologist to look into the finer details of it, but in centers where it is difficult to get all sorts of specialists, right, you need to know the basic thing. If it is, you find it difficult, you should always summon a specialist. Okay, the what can happen with neurological condition that can affect the airway, breathing, and circulation, right? Now what happens is that's loss of protective airway reflexes due to coma. Now if a patient comes, right, and this incident is wonderfully related by another mentor of mine, Dr. Bodley, right? The patient was I heard his video recently, and I saw his video recently. In that, the patient is taken out of the OR. The patient had a problem of the patient had a maxillofacial infection. He was drained, and the patient came out from the OR into the recovery. And all of a sudden, everybody feels that the patient has been reversed. They leave the patient, but unfortunately, the tongue falls back, and the patient collapses. Right. So this could happen. Okay, because of the loss of protective reflexes due to coma, and of course due to anesthesia also. The breathing difficulties are because of apnea, which result because of brainstem stroke, intracerebral hemorrhage, respiratory muscle weakness, for example, GB syndrome or myasthenia gravis, and circulatory collapse, right? So ABC can be involved because of the maxillofacial trauma also as a result of neurological injuries that happen. Okay. Now, what happens is that there are two kinds of patients. You've got the unconscious patient and the fitting patients, where you got the neurological involvement. Now, these are the different causes of unconsciousness where you have got, you could take a screenshot, or I think, Vijay, this is being streamed on YouTube also, I think, right? So you could always,
Yes, sir.
yeah, you could always check it up later. You can take a screenshot, or you can take the presentation from me. Because if I talk on everything, it's going to take more than an hour, and obviously you will be bored, right? Now, the National Institute of Clinical Excellence guidelines for the fitting patient includes that we have to secure the airway, assess the respiratory and cardiac functions, give rectal diazepam, because that is the easiest way we can get the patient. Because obviously, though I don't know why they say buccal midazolam, right? Rectal suppository will give the patient relief from the fits, right? If the patient develops into status epilepticus because of the head injury, obviously you need a neurosurgical intervention over there, and obviously the patient is theirs, and then the patient can be shifted to later on to us. Now I think I'll take a small break. If there are any questions, Jana, we can ask. Or
Yes, sir. Yeah. So you said about Glasgow Coma Scale for adults. What about pediatrics? Can you hear me? Do you have any Glasgow Coma Scale for the pediatric group?
I'm not
Audible.
yeah, there is a way of checking neurological
Yes.
status.
Yes, sir. For the postgraduates, because they tend to get question on pediatric trauma.
Yeah, you're absolutely right. But usually what happens is that, of course, uh, in such patients, the injury needs to be pretty severe. That needs to happen because they have got a large skull volume. The
Yes, sir.
cranium is large, right?
Yes,
So
sir. Yes, sir.
yeah. So now, how do I remember it actually? Just if you can just
Sir, I don't have it. Yes, that's one question I asked. It
yeah,
plus.
you're right, but that has stumped me actually.
Yes, sir. Any other questions? Vijay, sir?
Sir, we can move
Vijay,
on,
sir?
Rama sir.
Okay. So, what do we look out for? We look out for, see, you need to be very sure about the head injury, the whiplash, right? I'll be dealing with whiplash in a moment. Okay. Massive hemorrhage, which happens in the thorax and abdomen, right? You need to be very sure about hemothorax and hemoperitoneum. And also, what happens with the thorax is that there could be a penetrating injury that can lead to pneumothorax. So, in such cases, it is extremely important that we we do a thoracentesis, right? And we drain out that air. Okay, as well as if obviously if there is massive hemorrhage in the abdomen, then one can one needs to obviously refer the patient to a surgeon who will take care. Then because of hemothorax also there could be cardiac tamponade because the heart cannot expand, right? And one very important thing to note is the fracture of the pelvis. Okay, because in cases of fracture of the pelvis, there could be a massive blood loss. Right, one needs to take care that such fractures should not get displaced. Otherwise, they can cause a catastrophe to the patients. Okay. So this is the whiplash injury that I was talking about. Now, if you see, what can happen is that with whiplash, there can three things that can happen. One is that it can cause an injury to the cervical spine. The second thing is, if you look over here, there could be a injury to the ligament. Okay. Number two, what happens is when the neck turns forwards, right, it flexes. There is a chance that the brain will move from the front, right? From the back and move in the front. And what happens is, in such cases, you'll have the brain hitting which is near the crista galli and all those things. They can go and lacerate against the hard bony structures which are there. And similarly over here, you see the patient extending, and there could be a damage to the brain will tend to move back, and that will cause damage over here. So, and also that could be a condition where it moves back and forth, right, many times. So this could lead to a lot of contusion and sometimes even laceration, okay, to the brain. Now, what is important over here is something that we should know is the FAST. What is FAST? FAST is it's a kind of a scan, which expands as focused assessment with trauma, right? Now, it's a rapid bedside ultrasound performed by surgeons or emergency physicians for screening the blood around the heart to check pericardial effusion or abdominal organs after trauma, right? So this is something that is performed nowadays, and it's a standard protocol to have the fast scanning done so that we can rule out any massive hemorrhage which would be happening to the patient at the time of trauma. This usually happens with blunt trauma, right? So one needs to be very careful. Now, what is important is the ABC, and we'll be talking about it in just a while. So you have airway, breathing, circulation, and disability. Okay, so we'll deal with it one by one. So airway maintenance. Now, why does it happen? Okay, this happens because if you look at the structure, I think it's in one of the subsequent. Yes, this slide. Okay, if you look at this slide, it is like a matchbox zone. Okay, what happens over here is that nature has devised it in such a way that this particular part, that is the mid phase, it crumbles, right, or crumples, so that it does not allow the injury to be transmitted, the forces to be transmitted to the brain. Okay, what happens over here, again, if you look at it on a bigger perspective, you can see that it is nature has made it along a 45 degrees, so that ultimately it doesn't move here, but it tends to get displaced downwards, so therefore protecting the vital brain, which is over here, right? This article, which is by Dr. Roy Chaudhary, gives this wonderful, we do get such trauma, but not such an extensive trauma, which is seen over here. So in this particular CT scan, you can see the extensive damage that has happened, right? So this is something that would prevent the patient from breathing normally. So these are those situations where you need to give the patient a assisted airway, and in most of the cases one may have to perform a tracheostomy, and if one is not confident about doing a tracheostomy, one can do a cricothyrotomy, right? So this is something that is extremely cautious, that one should always look for maintaining the airway in such cases, right? This is a tooth that has got displaced in the airway, so that also can cause an obstruction, right? And usually what happens is that we may try to tell the patient to sit up, but then with a lot of injuries, it is difficult for the patient to maintain the airway on his own. Okay. So what do? We maintain the airway by obviously by putting an assisted airway, and then one should also be sure that cervical spine fractures, which you see over here, do not happen, right? It is it is extremely important to rule out C-spine injuries, and you may need to know how one can do. One needs to do an X-ray, which is by the Nexus. X-ray means I'm talking about imaging, and this imaging happens by using the Nexus criteria. Okay. Now, what is the low risk criteria? So that one need not perform radiograph. That is, there's no posterior midline shift of the cervical spine. There's no tenderness. There's no evidence of intoxication. There's normal level of alertness. There's no focal neurological deficit, and there's no distracting injury. So that means we may not have a cervical spine injury. If some of them are there, then one needs to perform some kind of an imaging. So this is the Nexus criteria. There's also a Canadian CT scan criteria that is important to know, right? And this is a Laerdal mask which is there. Usually in the West, they have these numbers 911, where the paramedics would come within 5 minutes and the patient is stabilized. Most of the maxillofacial injuries in a patient who is unable to get up, one should always suspect the patient of having a cervical spine injury. It is important that we don't aggravate the injury, because that can lead to catastrophic problems, right? So the way it is done is that it is passed very gently below the neck without altering the position of the patient. The lower part of the collar, that is pushed below the neck, and then you kind of get the two sides strapped together, right? So it is it happens that you can manage the cervical spine fractures that way. Okay. Now, the injuries that can see cervical spine, it could be anything actually. You can have a zygoma fracture and a cervical spine fracture in the same patient, right? So one needs to be extremely cautious about all these things. And if at all, now what happens is that if we do not have a Laerdal's collar or a stiff collar, you can just put two sandbags by the side of the patient. Somebody can just stabilize the head, right? And the patient is shifted to a better facility, right? This is how the Indian Jugaad system works, but it works nonetheless. Though, of course, we need to improve our healthcare facilities, right? If there is no cervical spine injury, right, we can do the chin lift and the jaw thrust position. Now, what this does is it maintains the patency of the airway, as well as it, you can see that the tongue is not it doesn't drop backwards. Okay. When to do a track? Now these are different situations, okay, where you may need to perform a tracheostomy. Okay, this is from the textbook of maxillofacial injury by Rowan Williams, right? And a wonderful book. It's out of print, but it was fantastic. So these are the different situations where you may need to do a tracheostomy. Immaterial, whether it is a central nervous system modulated or a physical injury to the sternum, right? So, or the thorax, right? Where the patient will find it difficult to move the chest, right? So these are the situations where one may need to do a tracheostomy. And if you look over here, this is something that is always of interest to us, a depressed fracture of the midface, which can cause blocking of the airway, the tongue falling back. And when does this happen? When does the tongue fall back in maxillofacial injuries? When there is a bilateral fracture of the parasymphysis, what happens is that the segment is pulled backwards. When it gets pulled backwards, obviously the tongue is going to find place in the oropharynx and block the airway. So immediately, if you notice that the patient has got a bilateral fracture, then one needs to perform. You can just do a simple stabilization and the patient will be okay. Otherwise, if one can put a Guedel's airway, that is good enough. Okay, but tracheostomy is the something that will be suited for the best. So this is the oropharyngeal airway or the Guedel's airway, right? So this is what happens. Oxygenation, which is given, oxygen is given at a rate of 15 liters per minute, right? It is humidified, okay? And this is something that obviously, which is the lifeline to the patient, okay? A patient who is breathing 100% oxygen can move 5 times more oxygen to the alveoli with each breath as breathing normal air. So this is the advantage of giving 100% oxygen, right? Make sure that it reaches the lungs so that the patient gets properly oxygenated. And how do we check it? The simplest thing, I mean, I need not tell to this group. We've got the pulse oximeter, the multiparameters which are there. You can always monitor the oxygen saturation, and sometimes you can in better units or better devices, you can see the end tidal carbon dioxide also, right? Hemorrhage accounts for 30 to 40% of mortality, right? Prompt hemostasis is imperative when there's significant bleeding. Now in maxillofacial injuries, what happens is that we may feel that the patient is bleeding a lot, but then patient does not get shocked by simple maxillofacial injuries. The simplest thing that one can do is, if you just try to get the fractures reduced, that will cause the bleeding to get arrested, right? So you should manipulate the fractures in such a way that it stops the bleeding. It could happen. I'm not saying that once you just reduce the fractures and then immediately the bleeding stops. It could stop. That is the best way, because it will form a plug, right? If it fails to stop, then we need to obviously incorporate certain measures, like we'll be dealing with it. Epistaxis, you can put a pack which is Vaseline impregnated, right? You can put a post nasal pack also, right? If it fails, all these measures, the local measures fail, obviously you can't use adrenaline impregnated gauze over here. If it fails, then you need to do an arterial embolization and intermaxillary fixation or surgical ligation of the branches of the external carotid arteries, right? Now, this is what I just said. It can look dramatic.
आज न्यूज आया है कोरोना से कोई नहीं बच सकता है.
This is a case of a gunshot wound. We see them nowadays happening a lot. We are near the CRPF area actually, so sometimes we get to see some gunshot wounds and all, right? But then the best thing is, just try to identify the bleeder, and then you can just buzz it in such cases, of course, and then you can stop it, right? If it fails, then obviously you need to do a Trendelenburg position. IV catheter, the best way to do it is to give a Foley's catheter, right? And there are different sizes of IV catheters which are available. the reperfusion is based on 3-for-1 rule. That is 300 mils of electrolyte for 100 ml of blood loss. Of course, the patient is not losing electrolytes or a plasma expander, so you need to give the patient blood or the blood that is lost. But in the interim, you can give some kind of a fluid for the patient so that the patient doesn't go into a hypovolemia. So this article which is there is from it's slightly unclear actually. So this is from the management of maxillofacial injuries by Dr. Roy Chaudhary. So clear the airway, right? Do proper suctioning, identify the source of bleeding, right? If it is extraoral, face or scalp, give sutures, right? And a pressure pack. If the bleeding persists, then do a transarterial embolization. If it is nasal, anterior means it's balloon tamponade or pressure packing. And if it is from the posterior side, then you do a balloon tamponade, which is which will serve the purpose. If it is intraoral, right, it could be a bony injury, then reduce the fracture. That is what I just said, right? And if it is soft tissue injury, then you give stay sutures. If at the end of it, if the bleeding still persists, then one may need to do a study, a vascular study, and do a embolization, right? So this algorithm which is there would help you in managing the bleeding that happens in maxillofacial trauma, right? Now the secondary survey, okay? Now the secondary survey doesn't happen till such time that the ABC is over, okay? And then after that, the secondary survey includes a head-to-toe evaluation, right? Complete physical and with the history, right? And that is done by what is called as AMPLE, right? So AMPLE is allergy. It's an acronym. It's for allergy. It is for medications. P is for past medical history, right? Last meal and events surrounding the injury, right? So how did it happen? How did the injury happen? So that is extremely important to know this, how you can carry out the secondary survey. I've got a video which will come just after this, right? So the exposure of the patient is extremely important. You've got to strip the patient, but you don't miss out on any kind of trauma that is there, right? So exposure of the patient is very important, and you have to run your now this is, I think, in the pre-COVID era, right? You can see the physicians are not wearing masks, right? Wearing a mask is very important. In the subsequent video also, you'll see that one needs to wear a mask, okay? So the patient is disrobed and every body part is visualized, palpated for injuries and bleeding site, right? So this is the video that I want to show you. Right? So what happens is that you have the patient, okay? And what this gentleman is going to do, unfortunately, not wearing a mask. So you have to check for all the ABCD, right? You're wearing gloves and then you start from the head part, right? So you move your hand, making sure that you're not disturbing the cervical spine, right? And this is the mnemonic that's going to help you. Decap BTLS, that is deformities, contusions, abrasions, punctures, burns, tenderness, laceration, and swelling. So if you remember the acronym Decap BTLS, I'll come to it at the end of it. So you examine the patient properly, run your hands, and then what you do is you also check for the blood, right? Which is very important. So you check for the blood if there is any, right? And you look in the ear and below the ear also, right? Because you won't miss the battle sign which is there, which is the indication of the middle. Sorry. I'm sorry, just moved here. Then what you do is you have to keep moving down towards the chest and the abdomen, right? Check intraorally. Okay. Check for the eyes. You can, the secondary survey also, when you do a secondary survey, you need to check for any bony injury, the step deformities. right? When you're doing a mid-phase, when you're checking for a mid-phase fracture, you can only check the orbital rims, okay, for the injury, because there's no other part which is going to show you a step deformity, unlike the mandible. So you look for the shoulders. You may get to see some clavicular fractures. Check for any rigidity, okay, or if the patient has got tenderness, then again move your hand below the at the back of the patient. Check if there's any bleeding, right? If there's any guarding or tenderness, then that gives you an indication as to if any abdominal trauma that could be there. You divide the abdomen into 4 parts and check each part, right? Check for the resonance if it is there. Okay, this is something, the basic things which can help you, right? Check for any signs of guarding, okay, or any swelling. If there's swelling, there could be a chance of a hemoperitoneum, okay. So then what you do is you again move down, right? Now, one difference that is over here is that the patient is wearing clothes. Normally the patient should be disrobed, right? Then you check for the pelvis, okay? Now again, when you check for the pelvis, you should not shake the pelvis because it's going to cause a lot of problems. If there was any injury, pelvic injury, that could get aggravated, okay? After you check the pelvis, what you do is you move your hands along the limbs, the lower limbs, okay? Do not tap them, do not shake them, but just try to move your hands continuously so that you can assess any bony injury which is there, right? So this per se may not be the job of a maxillofacial surgeon, but then it is something that one should know, right? So check for the other limb also, right? And then you can assess any injury that happens. Okay, check for the hands also, right? Both the limbs. Oh my God. So that is essentially what I was talking about, the secondary survey. Now, what does it include, right? So that is, we've just seen it: head, cervical spine, chest, abdomen, perineum, because sometimes, there could be perineal penetrating injuries which can cause a lot of bleeding, right? The muscular system, the maxillofacial structures, and any burns which are there. The secondary survey would give you an indication of all these signs, right? The battle sign, the raccoon sign. This is when there is an anterior cranial fossa fracture, and a battle sign happens because of a middle cranial fossa fracture. We should also check for rhinorrhea or otorrhea, which is there. Now, with this, we come to the end of the second part. Are there any questions, Jana?
Yes, sir. There are few.
Okay.
Yes, Vijay sir, please go ahead.
Sir, please go ahead, sir. That is sir.
Please go ahead. Go ahead.
Okay.
Shall I go ahead?
Sir, yeah, no, sir. There are few questions.
Okay.
On YouTube, there is one question. When we decide to admit a patient in intensive care unit?
Yeah. When?
Yeah.
When we decide. See, basically, what I said in the initial part of my lecture when we were talking about neurological injuries, right? A patient who would be in the ICU would have some sort of another injury also, associated injuries. So usually what they will do is that neuro injuries or abdominal injuries will take precedence, right? In such cases, the patient may be there in the ICU and then later on shifted to us. Like recently, we had a fracture. The patient is there in the neuro unit. If you remember the second or the third slide, the collage which I had shown in the center, right? Now that is a patient who would be there in the ICU because the patient has got neuro injuries. So once they decide that they will operate the patient, and then they will transfer the patient to us. Now there are two situations over here. First is that the neurosurgeon takes precedence, obviously, because the brain is more important than I may sound very, Max Fax may not like it so much, but what happens is that the brain takes injury over the maxillofacial injuries, right? If the patient doesn't live, then what can you do with the patient, right? So the patient's survival is very important. In such cases, the patient who's got a GCS of over 13 may be shifted to us for management. So these are the patients who would be there in the ICU. If the patient also has some airway issues, so obviously the patient would be seen in the would be referred to the ICU.
Okay, sir. That is the next question, please.
Somebody has asked, how do you examine the cervical spine injury?
Cervical, I told you, the cervical spine injury, if see all patients who got maxillofacial injuries and especially who are lying maybe on the floor or sorry on the road or somewhere, one should always suspect that the patient has got cervical spine injuries unless proven otherwise by x-rays. Okay, or if the patient is showing some signs of injury directly, right? So that is to the cervical plexus and all. If the patient has got problem with moving the limbs and all, so that could be a problem.
Sir, in continuation with this, there is the next question. Whether to prefer rigid or semi-rigid cervical collar?
Usually what happens is that again, the Laerdal collar is a kind of a rigid collar, right? So that would give the absolute stiffness to the area and not allow its mobility. But in case if there's some kind of a soft tissue contusion or something, then we can use a semi-rigid kind of a cervical collar.
Okay. That is, sir.
Fine, sir. I think we should go ahead now. There's
Okay.
a third party that's remaining. Yeah.
Okay, come to the last segment.
Unless Vijay sir is having any question.
If Vijay has a question, he'll answer it himself.
Yes, sir. So what type of intubation we prefer in an emergency scenario? There is one question from participant.
Okay. So, well, we can do routine endotracheal intubation. Now, what happens is doing a nasotracheal intubation may be a difficult thing if we do not have that expertise, or if the patient has got associated, mid-phase fractures. Then the best thing to do is to do an orotracheal intubation. If that also is not possible because of the sort of injuries that the patient has, then the only option left is doing a tracheostomy, right? And there's a difference between doing an elective tracheostomy and a regular emergency tracheostomy, where one needs to give a vertical incision and then reflect the tissues. The bleeding and all can be dealt with later, but what is most important is managing the airway. Another thing which I would like to point out here is, in that image which I had shown where the tongue falls back, okay, so one simple thing that one can do is to give a tongue stitch, right? Just pass a suture, a 2-0 suture through the tongue and put it on the drape, right? So that will prevent the tongue from falling back. Okay. So is that okay?
Yes, sir.
Okay.
Sir, what about golden hour?
Yeah. Golden hour means, obviously, are you talking about that trimodal thing?
Yes, sir. There are two, probably in relation to the head injury is asking, lucid interval and golden hour of treatment.
Yeah. So when you get such patients in the golden hour, it is management of the head injury that is extremely important, right? We take a backseat in such cases. The patient should be managed for the head injury or any major injury that happens, right? Otherwise, there could be a mortality at that particular time.
Yes, sir. So also there is now new concept of platinum 10 minutes.
Yeah, platinum 10 minutes, correct. So
thank you, sir. I think we can move on, sir.
Okay.
Golden hour is a critical period and then 10 minutes of platinum. Yeah.
Yes.
We can move ahead, sir.
Okay. So now we come to the proper secondary examination, secondary survey, where we see the maxillofacial structures, the scalp and the skull, right? There could be injuries which look very threatening, but then we can manage it very well. The scalp is a very vascular structure, so we need to give a proper closure to stop the bleeding, right? The ear should be looked for discharge of blood or the cerebrospinal fluid. If something happens like that, then obviously what has happened is that the condyle may have got impacted in the glenoid fossa, which is not such a common thing, but there could be a middle cranial fossa fracture that leads to leakage of the CSF through the ear that is called as CSF otorrhea, right? This is the battle sign, which is the fracture of the middle meatus. Sorry, I'm so sorry. This is the fracture of the middle cranial fossa, right? A pathognomic feature. You got the Coleman sign, which you see intraorally. Okay. The eyes should be noted for. Now, this is something which is a very dangerous thing which you see over here. Now, usually if there is, extreme hemorrhage, subconjunctival hemorrhage rather than in the cone, then obviously we are dealing with a case of retrobulbar hemorrhage. And this is an emergency. It should be operated as early as possible. I'll just come to it in a little while. Check for any restriction of eye movements. Okay. Check for the visual acuity. Now, obviously, we can just look for certain basic things, but for better examination, we need to have an ophthalmologist, right? Who would be the best person to suggest it, because we may not understand what is glaucoma, right, at that particular time. Okay, so we need to have a specialist looking into it. So this again is raccoon's eye, subconjunctival ecchymosis, right? And we need to examine the eye by retracting it. We need to use a blunt instrument for looking into the patient's eye, right? Now, subconjunctival hemorrhage. Now, this is a favorite question of an examiner that will come, because why is it bright red? Whereas just below that, when you look at the previous slide, when you saw the previous slide, you have an ecchymosis which is dark red, right? This is bright red. So the reason is that this is because of the semi-permeable membrane which is there, and that allows for exchange of oxygen to happen, right? Cornea is a semi-permeable. So it allows for the exchange of oxygen, and that is why it is through the conjunctiva, and that prevents the reduction of hemoglobin. Whereas in the previous slide, because it is below the skin, you see that the hemoglobin has broken down into its constituents, and that causes the issue, right? Retrobulbar hemorrhage and emergency. Okay. Now, what we need to do is to do a cantholysis and a lateral canthotomy, right? I must confess here that so far I may be fortunate, I don't know, that we may not have got to see such cases of retrobulbar hemorrhage, right? What we need to do is canthotomy and cantholysis. Okay, so this is the mechanism where you do a lateral canthotomy, okay, and then you gain access. Now, how do you assess that it is retrobulbar hemorrhage? When you compress the eyeball back, right? So it is difficult. There is very little compressibility that is there. So that is one sign. Second thing is the patient has got loss of visual acuity. The patient loses vision, right? And the time that you do it, when you do cantholysis and canthotomy, immediately within half an hour, you'll see that the vision gets restored. If not, because there is accumulation of blood in the uh, orbit, right? There could be compression of the optic nerve, and the patient loses vision, right? So it's an emergency that takes precedence over a lot of things. So it has to be done very fast, rapidly. Okay. This is another article, and one thing which can be done is that within an hour, if the patient comes, then you can do an ultrasound, and you can carry out the same procedure by doing a canthotomy, right? The nose, now when we do the secondary survey, the nose is also because it is present in the center of the face and it's a most prominent part of the face, you can get to see fractures of the nose also, okay? A very common thing. It may be missed during examination, and X-ray would help you to do it, okay? Gunshot injuries, we just talked about it. What is important is the airway and the exit, the entry and the exit. Now what happens is that when we are dealing with the gunshot injury, what you see is that the point of entry is small, and as the missile moves forward, there is dissipation of energy, and when it exits out through the exit portal, it tends to cause a greater damage. Okay, so maybe if you see this patient, maybe the entry point was here and the exit point was here, so that there is a large defect in the exit point. Okay, so in a blast injury, the patient could have a massive, hemothorax and hemoperitoneum. Apart from that, because of the blast waves, the patient could lose the hearing acuity, right? And there could be shrapnel which goes and gets embedded in the facial structures, right? So what is important here is that we should not get too much perturbed about it, right? We should do the suturing of the soft tissues back, okay, which will form the drape. And how do you how do you check that you are doing the right thing? The most knowledgeable points that we have, the anatomic point which are there, which can be restored, we should start suturing from there, rather than suturing from here and then finding out that we are not able to get a proper lip closure. So these are the known anatomic points where you can start suturing and you can get the face sutured back again. Now, obviously, this is something that has been done as an emergency measure. The patient may need to undergo revision surgeries to make him look much better, right? But then this is something that was done, and one should not get worried if you see the eyeball over here. This is one case, such a case which I saw when I was I don't know whether I was a resident or a lecturer in GDC, and such a similar thing happened. But of course, the patient was a very rich patient who had happened to come at that time, and then he shifted the patient to a bigger center in Mumbai. At that time, I'm talking about 90s, right? So the patient fortunately did not lose his vision. So you need to check the vision in such cases, and one should not get worried if you see the eyeball hanging somewhere over there, right? Okay. So this is yet another article which you would find very helpful. Okay. Now, what is the algorithm for the management of maxillofacial trauma? I think I'm nearly at the end of it. So if there is a blunt or penetrating injury, obviously the airway and breathing and circulation, they take precedence. Okay. So one needs to check the jaw thrust, do endotracheal intubation, cricothyrotomy, or tracheostomy. Now, what happens is that cricothyrotomy is something which is an emergency measure till such time that you can get somebody to do a tracheostomy. And why not? We should be trained enough to do a tracheostomy ourselves. For circulation, you need a large bore intravenous cannulation, right? You can use a 16 or 17 gauge cannula, right? And another important thing over here, when we talk about giving massive transfusion or massive intravenous fluids, the bore should be wide and the distance from the fluid source should be short, right? If you've got a long, the regular ones which are there, they've got a long, it's kind of the dead space to move the fluid is very long. So what you need to do is you need to have a shorter route of providing more fluid to the patient, right? If there is any coagulopathy, that should be corrected, right? If there is massive oronasal bleeding, right? Check for extensive soft tissue disruption. Check for a blunt or limited open wounds. Okay. Sorry, this is so sensitive, right? So you check for, you take the patient to theater and ligate if needed. It's extremely important that, sometimes in cases of intractable epistaxis, right, you put a pack, it doesn't happen. So what you can do is you can do a Caldwell procedure, gain access into the maxillary sinus, break the posterior wall, and then ligate the intermaxillary artery, right? For the posterior, if there's a blunt injury and there's a posterior packing, right, you do a temporary fracture reduction. If it fails, then do a transarterial embolization. If it fails again, then you should take the patient for direct ligation. And then at the last, you do a delayed maxillofacial repair. So it is important that we manage the patients for the bleeding as well as the circulation and most importantly, the airway, right? And as I said earlier, if you reduce the fractures, then obviously the bleeding would stop to some extent. But then it's not, it's not as easy as it says, because if you see the facial fractures, sometimes because of the thin bones which are there in the midface, it is difficult to get a proper reduction done at that particular instant. But for the mandible, it is good. So in near conclusion, I'm not in the conclusion, right? This is another emergency medicine article that comes from Australia. So the mandible fractures are bilateral unless proven otherwise, right? The maxillofacial injuries can be associated with the base of the skull fracture. CSF leak may be from the clear fluid leak from the nose, may be CSF uh, rhinorrhea, and zygomatic and orbital injuries may be associated with significant eye injury, right? A painful proptosed eye, like I said earlier, is a cause of extreme urgency and is a cause of a case of retrobulbar hemorrhage where you need to reduce or decompress the orbit, right? So the take-home message, right, is that early recognition and of the injury and appropriate therapy may be instituted. Resuscitative measures can be complex and require prompt decisions, especially in gaining a secure airway. Maxillofacial injuries, I need to stress, are a part of secondary survey, and systemic injuries obviously take precedence, right? Imaging modality should be utilized optimally. One cannot just rely on an OPG or a lateral oblique X-ray, right? CT scan is the gold standard for injuries. And also I need to say that when we are dealing with retrobulbar hemorrhages, right, one should do a non-contrast CT scan if there is needed, and of course ultrasound, which is there, right? Tetanus prophylaxis and antibiotic coverage, fluid replacement as indicated, and management of bony injuries is important as it provides the scaffolding. However, if we saw that, one of the last cases which I showed, the soft tissue drape is important, because if the soft tissues are left like that, thinking that I'm going to deal with the bony injuries later, it's going to cause a problem to the management of the that will cause an infection and so on and so forth. So one needs to be very sure. And of course, one thing that I need to stress over here is that one should not go for extensive debridement of the soft tissues, because the facial area is very vascular, so you need not go in for very extensive soft tissue debridement, and the vascularity is going to take care of the healing, right? The best outcomes occur with early intervention of a multidisciplinary team approach. And of course, it should include a maxillofacial surgeon who's got experience in such conditions. So that is why in many cities now you've got trauma centers and maxillofacial surgeons are a part of it, right? So these are the references, and I'll take questions. And I also have questions. Vijay and Jana, I have put it in such a way that there are some questions which the PGs would be asked during their viva. So that will be at the end of it.
That's excellent, sir. So there is a question: how do you manage retrobulbar hemorrhage?
We do a lateral.
Just now,
yeah, I think I dealt with it. You do a lateral canthod.
And what is the prognosis of optic nerve decompression? What are the chances of blindness if you don't do it? And what is the right time to do it? Or if you delay, how much?
Right time to do it is as early as possible.
And if you delay, if it is delayed, what are the chances of blindness? What are the percentages?
Obviously, the patient is going to go blind because there is going to be increased blood which is there in the orbital cavity. The orbital cavity is a cone, right? So there's going to be more blood, and the blood cannot be accommodated in that particular cavity to an extent, because you got the globe which is there. So in such cases, we should do a canthotomy and a cantholysis as early as possible, right?
Yes.
We could always take the help of an ophthalmologist or somebody who's well versed with it, right? I confessed in the beginning that I have not seen cases of retrobulbar hemorrhage in the 26 years I've been through. I was in Savangi, I was in GDC, and for the last 21 years I'm in VSPM. So unfortunately or fortunately, I've not seen many cases. But then this is the basic mechanism, and I'm sure that there are big trauma surgeons in our association who do this. Right?
Hello.
The golden rule is that as early as possible we should do it. Right? I think it's somewhere between. If the patient comes immediately, it's good enough. But within 1 hour or 2 hours, it should take place. Because then what happens is that the patient starts to lose vision. If we do the decompression early, then obviously the vision is restored.
Yes, yeah.
Hello.
Yeah.
So I would like to add a point.
Yeah, Prasad.
Yes, sir.
Yeah, we always give references to the ophthalmologist.
Yeah.
But in such cases where we suspect some retrobulbar hemorrhage or some extensive injury to the globe, then rather than a general ophthalmologist, an oculoplastic surgeon should be called.
Correct, correct.
And they are the best people to handle such injuries along with a maxillofacial surgeon.
You're absolutely right. And it so happened that there was a session in Nagpur, I think maybe a couple of years back. It was in 2018. It was an interdisciplinary approach. And in that person who's attached to the government medical college had talked about this. You're perfect, Prasad.
Most of the time, these patients are at the periphery center, and when by the time they reach to the main cities, there is already damage. That's how I have come across at least 3 to 4 cases of blindness. Patient have come to us after one day with a severe swelling, and nothing has been done to the retrobulbar hemorrhage. So
Yeah.
many times it happens.
So that is why I had stressed earlier that we should have a good, healthcare.
Yes, sir.
And I'm sure in the days to come, it will definitely happen.
Absolutely true, sir. They need to have a trauma centers.
Yes.
Yes, sir. Probably having maxillofacial surgeon at primary trauma care center will improve this scenario, sir.
Yeah, Vijay.
Exactly, sir. Because most of the centers they don't have.
Yes, because the Nagpur GMC has a dedicated trauma center, but unfortunately, because of COVID-19, it has been turned into a COVID hospital. But that is the need of the times. So, but then I am sure that in days to come, we'll see more and more towns and cities come up with dedicated trauma centers, which obviously would have a maxillofacial surgeon in it.
True, sir. Are there any questions from postgraduates?
Yes,
Please
sir.
go ahead.
Shenoi, sir. How to manage?
From postgraduates.
Sir, yes, from postgraduate only.
Okay.
So on the behalf of them, I am asking.
Okay.
How to manage animal bite wounds in primary care? What precautions we have to take?
Yeah, see, number one, it's not just animal bite wounds, but you have got cases where, like a bear, aswal jamanta tapan.
Yes, sir.
Yes, sir.
Yeah, we have seen a couple of cases where, they're dealt properly. So what happens is that you need to wash it copiously, right? You need to wash the wound copiously. If there's avulsion, then there's a problem. But otherwise, and of course, anti-rabies prophylaxis has to be given. And then later on, we manage the closure of such wounds. So it's very important that we, if it's a, and usually what happens is that they are the dog bite wounds, and which are seen in young children, right? Because we've got a very big stray population in our country. So they are the ones who would attack young children. It should be washed copiously, anti-tetanus prophylaxis, and then later on we do the soft tissue closure. If there's avulsion, then obviously we need to take some flaps at some point of time. Hello.
Vijay, sir, any questions from PG? Please go ahead.
I'm searching that only, sir.
I think they are taking a revenge because we usually ask them questions.
No, sir.
Yes.
So we had 257 participants. So maximum like Tendulkar batting.
No. Nobody is yet to beat the record of Gokul.
Gokul, sir.
Gokul was, I think it was like,
sir, but yours is not out, sir.
Sir.
Yes, Mukul, sir.
Sir, yours is not out. People have not left, not moved from their seats, sir.
Right.
They're awestruck, sir.
Mukul, thank you so much.
Mukul, sir, any question from your side?
Mukul, if Mukul has a question, he'll answer it himself. I had great times with Mukul when we were in GMC, and we had a patient who insisted on getting a bone plate. Bone plate using an ORIF was not very common at that particular time. I mean, it had come, and Mukul's thesis was basically on rigid integrity.
Yeah.
So there was this Munna who kept coming and begging us.
Munna, if I mistake not.
Yeah. And ultimately, I don't know, he got us to do it. So it was an established
But,
modality.
but Rama, congratulations,
Sir,
excellent performance as
sir,
usual.
one more question. Hello.
Yeah.
Yeah.
Different pupillary signs in neurological deficient cases.
Vijay, see, this thing would take a lecture on its own, right? I have not included it so much in detail, right? And
I agree.
yeah, so I think we'll talk about it when we talk about neurological injuries, right? Because
Yes,
I,
Yes, sir.
I need to spruce up my knowledge on
yes,
that,
sir.
and I would not be the
Yes.
exactly the right person to talk about eye signs, right? We can always
Yes.
get some
You can have
collaborative.
one more lecture for a neurological assessment. Like,
Yes,
Yeah,
Yes, sir.
Rama, I want to ask a small question. Can I?
please, Mukul.
Vijay and Gardi, if you'll permit. I want to know how much is the longest time, you have a primary injury and the maxillofacial injury is ignored. What is the time duration you had? We've had sometimes where patients had head injury for nearly, doesn't recover. And
Yeah.
by the time he comes back to our OMFS unit, he's really into malunited fractures. And it's really a bad situation. So what is the long, hello? Have you seen such cases also?
Yes, yes,
Where
yes.
you had to wait for long, and how much is the longest duration? Then what do? You plan to go in for refracturing, or you plan for an orthognathic surgery in such a case? Because every time we are in a quandary, whether we should really go and refracture, or we should just ignore the fractures now and then go in for a osteotomy. So we always we can't decide that many a times. Because sometimes refracturing is difficult, especially if you have a condyle which is there. So we always, once few months elapse, then we are in this two minds.
So, Mukul, we had a
Yeah.
few cases like that actually, but then essentially we managed it by refracturing. We
Okay,
did
refracture.
for orthognathic surgery at that point of time.
Right,
Uh,
right.
Refracturing, because I mean, I need not tell you this, but then obviously it is the other injuries which take a precedence.
Yeah,
Because
that's what.
we are all trained to carry out orthognathic or kind of
Yeah, exactly.
get the malpost fracture back into a malaligned fracture into its
Right,
place.
right. Yeah, I know that happens many a time nowadays because there are so many severe road traffic accidents, and they come to us very late. By the time really the fracture is reunited and becomes a difficult thing.
And
Good, Sharama.
decision, yes, sir. In this decision depend like
Is my audio bad or I'm not able to
No,
listen?
no, Vijay's audio is bad. We could not hear Vijay. Can you repeat that, Vijay? Hello. We have lost him, is it? Hello.
being person, they
Yes,
are
some
wearing
audio.
protocol.
Vijay,
Hello?
we lost you. We could not hear you. Could you just repeat what you said?
Sir, like in a neuro setting, most of the time neurosurgeon is in the deciding position. So
Right.
it depends a lot depend on his decision. Fortunately, I'm working with at least 2-3 neurosurgeons. So few of them say wait. Few are very good. They say that this may take a time. So you proceed with the intervention.
Okay. See, when I was having a discussion with my neurosurgeon, and which I told in my talk also, that if the neurosurgeon feels, Mukul,
Yeah, I'm hearing, Rama.
what the neurosurgeon said is that, if we feel that, the patient does not need a very extensive neurosurgical management, then to
Right.
avoid the second anesthesia, you can operate with us.
Right.
That's the way to go about it.
Right.
So that is the protocol that we follow.
Exactly.
And
Very true.
usually what happens is that, this is the unfortunate the drawback of our healthcare system, that, the orthopedician would take care of the femoral fracture or whichever fracture and then refer the patient to us. So I've talked so many times that, why can't we do it together? So, that will spare, because, okay, you may use spinal anesthesia, but there's no harm in using general anesthesia because all of us would be comfortable, and we are working at two different ends. So it doesn't matter.
Very true, Rama. Absolutely agree.
Yeah.
Excellent presentation, Rama. Thank you so much, dear.
Thank you.
Mukul sir, can I come in for a minute? Hello.
Yeah, please.
Sir, this is Anuj.
Hi, Anuj.
Yeah, hello,
Wow.
sir. We had a similar patient, sir. A young chap met with an accident, had multiple facial fractures and head injury, and he was operated by neurosurgeons. And then we saw him eventually 2.5 years after his neurosurgical procedures were performed. He was stable.
Yeah.
Right.
And the reason for delay was his parents were not willing to subject him for one more surgery. And now this guy was growing young and going to the college. He was more concerned about his aesthetics. So that is one more factor. Apart from neurosurgeon and the maxillofacial, I think
Patient himself.
the family and the patient himself for them to report late for surgery.
Agreed, Anuj, agreed. And many a times what happens is when you have a condyle expression, it becomes a real tough call to then manage these malunited condyles, you know.
Yes.
And this chap they come to you after 2.5, 3 months.
And there's one thing which I actually remember a case which had come to us about a year back actually, and I am not pointing fingers at any specialty because we could also do something wrong at some point of time. Medical science is not a perfect science. So this person had got I don't know, thousands of plates across his the jaws, right? And the patient, who was earlier looking pretty smart, had turned out to be he was a ghost, and he had psychological issues because of that. So this is what happens when we don't address it properly. But then this is not the scope of my lecture to talk about it. But since we just talked about delayed fractures and all, so this is something that happens. So it's very important that how the concept of occlusion, which is so much ingrained in us, that is something that would help us in dealing with maxillofacial fractures. The other specialties also do a good job, no doubt about it. But then this is something that which is something the greatest strength of us.
You said it, sir. That's absolutely correct.
So these are a few questions that I have. If there are no more questions, these are a few questions that I have, which are usually the kind of the question answers or the essay, the theory questions, or even during the Viva that So, and I am very fortunate to have a wonderful team over here. These are my backbone. I just sit and talk and they do the work, right? So you have Kshitij, Rahul, Nilima, the giant in the center, Brinda, Pranav, and Sandeep, who are excellent surgeons, right? They help me a lot in all ways, right? And this is my team who usually does a great job with my presentations. So thank you everybody over there.
Well done, Rama. One last question. There are always more females in your team or what?
I knew this was to come. And that is the very intent by which I kept the slide actually.
Is the most dynamic personality. There are always female around him.
No.
Always.
So
Now you search for Rama, you search for a crowd where there are females and see Rama in the center in a conference.
Here he is.
Rama sir.
Yeah.
Sir, can you stop the screen sharing? I will share the tomorrow's flyer.
Just 1 minute, just 1 minute. Thank you. I want to
thank.
I want to thank Maharashtra State AMSI for giving me this opportunity to speak. I am honored by this particular occasion that they've given me to speak. Thank you, Vijay. Thank you, Prajwalit. Thank you, all the office bearers and all the audience who listened to me for the last 1 hour and 1.5 hours. Thank you so much. I'll stop sharing.
Rama sir, it is an excellent presentation, very comprehensive and excellent. I mean, every postgraduate will be really, I'm really proud of you. Every PG will be benefited out of it. It's extremely difficult to cover everything in such a small time.
Thank you,
congratulations.
Well done, Guardian. Well done, Rama. Very well done.
Thank you, Mukul.
Thank you, sir.
Hello. Please hold on for a moment.
Yeah, we are holding.
Yeah.
We will hold it for as long as you ask us to hold, Vijay.
Shenoi sir, kindly accept this e-certificate from the association.
Yeah, thank you, Vijay. Thank you so much. It's a very big honor for me.
Thank you, sir. And tomorrow we have next session lineup. That's on mandibular fracture by Dr. Smriti. So kindly stay tuned. We'll see you tomorrow 6 p.m.